This urinary catheter video guideline is brought to you by the Clinical Operations Council of ACE Physicians and Evidence Care.
The goals of the guideline and this video are to implement evidence-based practices for the utilization of urinary catheters in the emergency department with the aim to improve the quality of care, safety, and cost effectiveness. First, some background. CAUTIs are a significant source of healthcare-associated infections and are estimated to cause
Up to 75% of hospital-acquired UTIs.
And since many urinary catheters are placed in the emergency department, it is important to focus in this area. This diagram highlights some of the areas in which urinary catheters can be a source of urinary tract infections. First, at the insertion site, which seems obvious, but also along the collecting system from the tubing if there's breaks in it, and even from the collecting system if there's backflow at some point down the line. But even if we use perfect aseptic technique and the system is well maintained, we know that these urinary catheters still pose a risk for urinary tract infections over time. And if you notice that it's well documented that biofilm forms around the catheter, and through this biofilm, bacteria can come up through capillary action and enter into the bladder and become a source for urinary tract infections. This video and the recommendations are based on evidence-based medicine from the Center for Disease Control and the American Hospital Association and their working committees. There are three major strategies for reducing CAUTIs in the emergency department. First really would be eliminating unnecessary urinary catheters when possible. And there is a listing of appropriate indications for urinary catheters that has been put forth by the CDC, and so we're recommending that policies be put in place in which there be formal physician orders that have to list the appropriate indication prior to the insertion of the urinary catheter, and that this process be integrated into the electronic health record at that site. We'll talk more about that in just a moment. Other best practices include use of condom catheters and bladder scanners when possible. Second major area of reducing CAUTIs would be to assure aseptic insertion, proper securing of the urinary catheter, proper positioning, and maintenance of a closed collecting system. We're getting better and better at doing this all the time, and the product manufacturers or the kit manufacturers are doing a better job of developing these systems and educating our people for doing that. And then finally, third, monitoring how well we're doing. Monitoring how well we're following indications and avoiding contraindications, as well as monitoring how well we are actually doing at inserting and maintaining the urinary catheter and the collecting system. So this is a listing of the accepted indications, and we're going to go through many of these as they apply to us in the emergency department. First would be acute urinary retention or obstruction. Well, that one is obvious. But another indication is for accurate measurement of urinary output in patients that are ICU level patients. So severe septic patients or other severe patients that are requiring ICU level care in which monitoring of urinary output and temperature is important. A catheter would be an indication. Another important indication is for immobilization for trauma and surgery. So if you have a patient with a significant spine, pelvic, or hip fracture and they can't use a urinal, using a urinary catheter could be of use to them. And then there's also a case that we see quite frequently in the emergency department, and that is the assisting of healing of anything greater than a stage 1 perineal and sacral decubitus wounds in incontinent patients. So if there's any skin breakdown or deeper breakdown and the patient's incontinent, then a urinary catheter is indicated. Finally, hospice, comfort level, and palliative care patients are an accepted indication. And then one more issue to mention, that if your particular hospital has a specific indication that is unique to your center, there is room for implementation and to be done so on a formal basis. This is a great list, and probably just as important, shows some of the inappropriate utilization of urinary catheters. So no longer should we really be putting these in place if we can avoid it in patients that are incontinent, if they have morbid obesity, if they have chronic confusion and dementia and they're incontinent, and by patients' request or clinicians or families' request. So we really need to do a good job of educating our patients and our providers on how to avoid urinary catheters for these indications. And while staff convenience and workloads are very important, we need to be sensitive to the risk and benefits. The American College of Emergency Physicians feels that this is such an important issue. It is one of their choosing wisely criteria. And then finally, let's talk about some of the frequently asked questions. So number one is, why don't we just educate people and not make it a formal process in which there has to be an order with a required indication? And while we all recognize that education is important and has its role, that until we hardwire processes in place, they won't be as effective. So for the most effective, hardwiring in place with a physician order in your EHR is probably the best way to go. We talked about hip fractures in patients. So yes, if a patient has a hip fracture and they can't use a bedpan and they can't use a urinal or a condom catheter, yes, it is, and they're having significant pain or instability of the fracture of the spine, pelvis, or hip, yes, they can use a Foley catheter. And then we talked about this as well. Why focus on the ED, and why does the AHA have a specific program for the ED? Is that so many catheters are actually placed in the emergency department, and retrospective reviews and show that so many of them were done in the past without clear indication or physician orders. And a few notes about guidelines. These guidelines are an accepted pathway when acceptable and are not intended to establish a standard of care or replace provider judgment. Each patient is unique. And here's an example of a reference document that's available on our website. It can be downloaded and shared. And this is a link of some of the websites that are available, the ED Prevention CAUTI website, the Center for Disease Control, and the AHA. Thank you for watching this guideline. Your feedback is welcome.